So, good morning, everyone. It's a privilege here, and I thank Dr. Deepak, Dr. Anand, and the whole team for organizing this. I remember when we were fellows and we were quite poor economically, so we had to go to Pune or Chennai to do this course. And I think now everybody is so fortunate to have this right in town near to your home. So, my topic at hand is cardiac arrhythmias and how do you manage an intensive care unit. So, I'm a physician by training, and the way we look at arrhythmias as a physician and then you convert yourself to an intensivist, these are two very different things. Because as a physician, you're looking more at the rhythms, the exact morphology of the ECGs, and a lot of nitty-gritties. As an intensivist, you are more into rapidly preventing deterioration of the patients and taking steps immediately with quick analysis of the ECG. You're not going into a lot of nitty-gritties of the ECG. So when you look at cardiac arrhythmias in ICU, very often up to your 15 to 20% of your ICU admissions will have some or other form of arrhythmia. But the thing that is different is that they don't normally come with arrhythmia to the ICU. They develop an arrhythmia during the ICU stay. So that is different. Uh, the management again is little specific to ICU is that the forms of arrhythmia that you see in intensive care would be mostly supraventricular. You see a lot of atrial fibrillation, APCs and VPCs. Your choices of drugs would be limited to the fact that is your patient stable, is your patient having renal failure, hepatic dysfunction, does he have any pre-existing cardiac anatomical defects. So these things would play a lot of role in your decision regarding what kind of management you want to offer. So in my talk, I would like to limit myself to these three things. One, how do you approach cardiac arrhythmias in intensive care unit? Second, discuss the most common form of arrhythmia, that is atrial fibrillation. It is like the common flu. It is very much prevalent but doesn't kill as many. But then you have the other form of arrhythmias like coronavirus, the ventricular arrhythmias. You don't find them very often, but they lead to a lot of mortality. So what is unique about arrhythmias in ICU? Number one is most of the etiology is non-cardiac. And what you do for arrhythmia is you do a cardiac consultation. So first thing is you see an AFib, you call a cardiologist. And most of your etiologies are non-cardiac. So you'll have a patient who's hypoxic, hypotensive, electrolyte abnormalities, drugs, septicemia. All of these are triggering those arrhythmias rather than the primary ischemic pathology of the heart. The second thing is that most of these arrhythmias are associated with increased mortality. Why? Because these are a feature of the severity of the disease. So, severe the disease, more arrhythmias you would see. So, those arrhythmias correlate directly to the multi-organ dysfunction or the sepsis or the shock that the patient might have. And thirdly, standard approach of arrhythmias in ICU is not very clear to a lot of people because in most of the arrhythmias, the only drug you're giving is amiodarone. Anything amiodarone, right? But then over the years, we realized that the conversion rate or the rhythm conversion stabilization rate of amiodarone is way less than a lot of drugs that we normally don't use. Reason is one, we may not be aware. Two, they may not be available in your hospital. And that is what we'll discuss during the subsequent slides. This is one of the studies which looked at the risk factors and clinical outcomes of arrhythmias in intensive care unit. Now, if you can see, almost one third of the arrhythmias are supraventricular, and the majority of that 30% is atrial fibrillation. Okay, and if you just take it forward, another 28% are premature supraventricular contractions, which we commonly see as APCs. So if you combine the supraventricular and the APCs, more than 50% of what you see is supraventricular APCs and AF. And if you are looking at a topic of cardiac arrhythmia in ICU, I think this needs a heavy weightage. Well, this is 50% of what you do. But even though the ventricular events are less, but they tend to kill. They're mostly terminal rhythms, patient very sick, and they need a lot of immediate attention. So this becomes important because these rhythms add to mortality. Now this study said that between medical patients and surgical patients, the arrhythmias behave almost similarly. So there is not much difference between post-operative arrhythmias and very sick septic patient in ICU. The treatment and the outcomes are really the same. They also suggest that the acute myocardial ischemia and AKI are related to development of supraventricular arrhythmias, and that is why you see a lot of supraventricular arrhythmias in ICU patients. Very important, the premature complexes do not add to morbidity and mortality. So APCs, you see them very often, they don't do much. You just look at electrolytes or maybe the hypoxia or some drugs, but they're not killing your patient and not adding to morbidity. But supraventricular arrhythmias like atrial flutter fibrillation, they add to morbidity. They don't really kill that much. And lastly, the ventricular arrhythmias are independent risk factors for mortality. Very, very important. Just to emphasize the point, how CSE will look at the rhythm abnormalities. A very, very simple approach. You see a rhythm abnormality, arrhythmia, a rhythm which is not normal. You look at, is it a fast or a slow rhythm? Is it a brady or a tachycardia? Then you look at the site of origin between the supraventricular, ventricular, or maybe junction. And how do you differentiate that? So we'll keep it interactive. How do you differentiate supraventricular from a ventricular rhythm? The QRS complexes. So if you have a narrow QRS, it is supra, and if it is broad, it is. And then of course you have variation. You may have a bundle branch block, and a supraventricular rhythm may look at a ventricular rhythm, or you may have an accessory pathway. And this is the area we are not really going to dwell a lot on, because that becomes more of medicine than intensive care. Okay. And lastly, but the most important is, what is the next step of management depends on, is your patient stable or unstable. And when you say unstable, it doesn't mean really shock. It means features of hypoperfusion. That means somebody who's maybe have hypotension, high lactate, have a decompensated heart failure, ongoing cardiac ischemia. Any of these features qualifies as an unstable patient. Okay. Now let's see a case. This is somebody we have in our ICU, 72-year-old male who's got a mitral stenosis, valve replaced, and hypertensive, who doesn't bother to take medicines, mostly uncontrolled, on chronic anticoagulation. This gentleman came to us with a 1-day history of altered sensorium and left-sided weakness. If you can see the CT scan here, you see a large SDH, fronto-temporoparietal, a large SDH, midline shift, and herniating. And this guy comes to us with a blood pressure of 90/60 and heart rate of 130, and this is the ECG. Okay, can you all appreciate the ECG? Is it visible to the backbenchers also? Okay. So can you tell me what is the rhythm? Loudly, atrial fibrillation. Okay. So just to make it a little more clear, I just thought the rhythm strip is easier. So how do you know it is an AFib? So one, is it fast or slow? It is fast. Okay. Can you see any proper P waves? No. And can you see the RR interval is variable, right? So these three features tell you that this is most probably atrial fibrillation. The atria is beating at a rate of 350 to 500 beats per minute, and the ventricular response through the AV node is somewhere between 100 to 150. Okay. Okay. Now, when you have this patient, you have basically two priorities. One is regarding the rhythm, you control the rate or rhythm conversion, and two, you look at the possibility of anticoagulation, short term as well as long term. There are two parts: rate rhythm control and decision on anticoagulation, short term and long term. Okay. So, with this patient, what do you think is the next step in management? You want to convert him medically using amiodarone. You want to do rate control using diltiazem. You want to do electrical cardioversion with 100 joules, and you want to do an echocardiography. Echo, how many say echo? All, or somebody has a different feeling? Echo, keep it interactive so I also don't sleep. Cardioversion, medical or electrical? Electrical. Shock में इसलिए ना? No.
Echo can be done, but medical cardiology can be done simultaneously. Echo should be done to look up the wall status actually.
Okay.
But simultaneously you can cardiovert it medically, not
You
electrical.
can't do seven. You have to do one by the other, ना? So एक चीज पहले होगा, एक बाद में होगा. So you have to do echo first or a cardioversion first.
I'll go for the cardioversion first.
How many for cardioversion? 20%. How many for echo? 10%. Okay. How many don't want to give an answer? The rest. Okay. So this answer actually is echocardiography. But when you said electrical cardioversion, and I'll explain subsequently, it isn't an absolutely wrong answer. Okay. So I'll tell you why. So because these diseases are quite complex, and we'll try to see if we can make it simpler for us. So for the atrial fibrillation, and I'll try to cover AFib in detail, this is the guideline, go-to guideline. I think this is some 300 pages, and thanks to you guys, I had to go through all 300. So this is a 2020 update from a 2014 guideline regarding management of AFib. Now, when you look at AFib, let us first define AFib, okay, atrial fibrillation. A supraventricular tachyarrhythmia with uncoordinated atrial activation and consecutively ineffective atrial contraction. So what it basically means is atria is going very, very fast at a rate of 300, 350 plus, and it is just going like this, right? It is just shivering. There is no squeeze. So the ventricle loses the squeeze, which adds to the 20% of the LV filling and the cardiac output. So eventually, because of this lack of squeeze, 20% less LV filling is there, which leads to the hemodynamic part of it. But with just 20% loss, somebody should not go into shock, right? Rest 80% he is getting, right? Because over long term, the high rate causes a form of cardiomyopathy. So the LV squeeze is also compromised. Hence, in long term, the control of the atrial fibrillation is important, because if you leave it uncontrolled, the LV will also get compromised. The electrocardiographic characteristics of AF means an irregular RR wave, we know since MBBS days, absence of a distinct repeating P wave. The word is distinct repeating. You may find a captured P wave at times. You see a small P wave. These are not P waves, these are called F waves, fibrillatory waves. So if you see a rhythm strip of an AFib and you find one P, don't get too excited that this is not AFib. This might be, this is called F wave or a fibrillatory wave, a capture of the atrial activity, very, very rarely seen. And irregular atrial activations. Currently, there are two subtypes, clinical AF, of course, when you have symptoms, and non-clinical or subclinical, when you don't have any symptom, you just did an ECG and you found the patient was in AFib. The risk factors. When you look at the general population, AFib is very common in the Western population, almost twice as common as we see in our country or the Asian population, because of the ethnicity and the genetic factors and the advancing age and the male sex characteristics. At the same time, added by increased alcohol consumption, smoking, obesity, all of these things. But anybody who has got a comorbidity in the form of diabetes, hypertension, smoking, COPD, name it, LVH, all of them are predisposed to develop AFib. So in the general population, a lot of people have AFib, asymptomatic, and that adds to the morbidity. It doesn't stay silent for long, it adds to the morbidity. In our case, this factor, the acute illness, is the biggest risk that our patient goes into atrial fibrillation. Okay. Now, a few terms that we used to use previously, we are not supposed to use now, are lone AF, valvular, non-valvular AF, and chronic AF. Please don't use these terms. These are abandoned. What we're supposed to use is first diagnosed AF. This is a AF irrespective of the duration that you found for the first time. And most of your patients in the ICU are these. Because you never know what was the previous status, you don't have a previous ECG, and for you, they are the first diagnosed AF that you saw. Then you have a term called paroxysmal AF, which basically means that the AF lasted less than 7 days, it reverted by self or by some intervention. So this is a short duration paroxysmal AF. Then you have a persistent AF, something that lasted beyond 7 days. You are unable to control beyond 7 days, and there are 20% of AFibs which are persistent. Okay. Then you have two confusing terms, long-standing persistent and permanent. Now long-standing is defined as an AFib lasting more than 12 months, 1 year. Okay. And you are still trying to treat to a rhythm conversion. That's important. You're still trying to treat not to rate but to rhythm conversion. If somebody decides in 1 year or less than 1 year that this AFib will not respond to a rhythm control measure, let us forget about the rhythm and control the rate, that becomes a permanent AF. It's a therapeutic attitude of the physician and the patient कि ये ठीक नहीं होगा, इसको सिर्फ rate control करके छोड़ देते हैं. At any point in a permanent AF, you decide, no, I want to rhythm convert. So that permanent AF becomes a long-standing AF. Okay. Okay. Now about the treatment. In hemodynamically unstable patient, you have cardioversion, which you can do medically as well electrically. And this is mostly, as I said, not just low BP, but ongoing features of hypoperfusion. In hemodynamically stable patient, you have a big debate between rate control and rhythm control, which we'll discuss. And this is the most important. In a lot of AFibs which are stable, just correcting the potassium, magnesium, calcium, hypoxia, taking off a drug corrects the AFib. Very, very important. So don't just jump on amiodarone and forget about it. Look at all the factors that are triggering that AF and correct them. And lastly, decide on anticoagulation in two parts: short term, 4 weeks, and long term means lifelong. So we'll discuss how we decide on that. Okay. In 2000, around 2000, 2005, the things were clear by a lot of trial data that rate control is as good as rhythm control. So no advantage of converting the rhythm. This is the firm trial or the staff trial. All of them said rate control kafi hai. And then this meta-analysis also came in 2012 that rate control is equivalent to rhythm control, no superiority of one or the other on all the endpoints, and we are happy. But as in all cases, you are never happy for long. So 2020 in NEGM we got the EastNeft trial 4. Okay, this trial, I'll just not confuse you with the data. What they said is in any substrate of the patients rhythm control better than rate control? And they found that if somebody doesn't have any cardiovascular risk factors such as age is less, no hypertension, no diabetes, no CAD, XYZ, then rate is equal to rhythm. But if somebody has a shorter AFib of less than 12 months, is symptomatic, and has got certain cardiovascular risk factors, the rhythm control is superior to rate control. Please mind this data, very, very important, because everywhere in the book it is written rate equal to rhythm. But nothing is true for everyone, and this is the subset of patient where you may attempt a rhythm control in certain patients. EastNeft trial. Okay. Now regarding the electrical cardioversion. So in this patient that we had a patient who's got features that he may be a chronic AF, not just a paroxysmal. He may be a long duration, large LA, possibly a mitral valve pathology on anticoagulation. And in these patients, you would need to know that is there a LA clot or not before you cardiovert. They are unstable, you do cardiovert. Even if it is with amiodarone, medical cardioversion, electrical cardioversion, you need to rule out the LA clot, most commonly present in the posterior part, the LA appendage, which has a least flow of blood. Okay, and for that you need to do a transthoracic or transesophageal transesophageal echocardiogram. That has to be done because transthoracic doesn't give you the LA appendage. Okay. Now, in a patient who needs emergency cardioversion, these are the few points I like to, and then you will understand why you are not wrong in doing the cardioversion. If somebody is on anticoagulation, on vitamin K antagonist, and he has a therapeutic INR of 2 to 3 within the past 4 weeks, and if he is on NOACs and not missed a dose in the last 4 weeks, and you don't have the capacity to do a transesophageal cardiogram, you may still cardiovert these patients. Why? Because these patients have a very, very low risk of having a clot and embolism. Okay. But if you're not on anticoagulation and the known duration is less than 48 hours with no structural heart disease, that is the risk score of CHAD VASC of 0 in men and 1 in female, the risk of clot embolization is again very, very low. Then you are not on anticoagulation, low risk patient. If you cardiovert, the risk of embolization is 0.2%. 0.2% not to be negated but very low. And the benefit of 4 weeks of anticoagulation is also limited, but still it is recommended to have a transesophageal echocardiogram and cardiovert under a cover of heparin and followed by an anticoagulation of 3 to 4 weeks. Did you get that? Should I repeat it? So if you have a patient who's in emergency, you don't know the duration of AF, first time presented, unstable, you want to cardiovert. If you have the capacity, please do a transesophageal cardiogram, rule out a clot, give 5000 units stat of heparin and cardioverting. Okay, followed by 3 to 4 weeks of anticoagulation. If somebody has an AFib of 30 seconds, the guideline stays still go ahead and anticoagulate for certain duration of time. Everybody doesn't agree to that. A lot of people have like one episode of AF. Why do you anticoagulate for in a sick patient for 4 weeks? That's debatable, but that is what some people may do. So, but here you have to give a shot of heparin, rule out the clot and cardiovert. In case LA clot is seen and the patient is in shock, can you cardiovert in any circumstance? Answer is strictly no, you cannot. You cannot do that. Okay. The doses of cardioversion in a biphasic mode, of course, are lower than monophasic, For AFib it is 150, and for the rest I have given it here so that you remember the doses. At times AFib we convert with 100 joules also, but just your luck. One very important thing about cardioversion. If you use an antiarrhythmic prior to cardiovert, your dose of cardioversion goes higher. So, for example, I had given amidaron and then I decided to cardiovert. My dosage requirement for cardioversion will go up, and that is true for almost all antiarrhythmics used prior to cardioversion. One important point. Okay. So, what other things are cardiovert medically? We know of only amidaron. And look at this, flecainide and propofol are way more superior. You have almost a 78% chance of rhythm conversion as compared to 44% of amidaron. And how many of you in this you have used flecainide? One. Okay. So two, one and a half possibly. Okay. So we are at time not using because of lack of knowledge or lack of availability of drugs. If we decide on rate control, we have beta blockers, we have CCP and we have digoxin. Okay. How do we use beta blockers in CCP? Somebody who is not in shock, not on vasopressors, you can use beta blockers. Beta blockers are good for long-term maintenance also. CCBs, if you somebody has got no LV dysfunction, LV is good, you may decide on this, and again a safe drug you can use as an infusion, as an oral drug. So CCBs are more commonly used in beta blockers because beta blockers have a problem with all the COPDs, asthma and all. Na? So probably the CCBs are used way more often than beta blockers in acute management of atrial fibrillation. But when you have a patient who's got an LV dysfunction, the drug of choice here becomes digoxin because it does both the LV squeeze and the rate control, AV nodal blockage. But the problem with digoxin ICU is you mostly have potassium issues and you mostly have renal failure issues. So you're very good to give that initial shots and load them with digoxin. And then you're thinking, how do I give him maintenance therapy? I don't have digifab. What do I do? What I do? So that's the problem with digoxin. And I am quite keen on digoxin. I use a lot of digoxin. Okay. Regarding anticoagulation, so one I said was a short-term anticoagulation. You don't have to put mind to it. You have no contraindication. You go ahead with the short-term anticoagulation. About the long-term anticoagulation, possibly sometimes you would be involved in the decision when you have to go through the AF three-step pathway. The first step is patient with atrial fibrillation eligible for anticoagulation, right? Then you look at does he have a prosthetic valve or sphere on moderate mitral stenosis. These patients should never be given NOACs. All AFib prefer NOACs. For this subset, never prefer NOACs. Always give vitamin K antagonist. Then you assess step 2 is the chances of having thromboembolism versus chances of having bleed. How do you assess thromboembolism? You look at the CHAD-VASc score. If the score is high, you have a higher chance of thromboembolism. If your HAS-bleed score, which is a bleeding score, is low and the CHAD-VASc is high, go ahead, that is a step 3, go ahead with oral anticoagulation. If it is the other way around, your CHAD-VASc is lower and your HAS-bleed is more than 3, 4, 5, maximum score is 9, then you decide this patient on a case-to-case basis. A high HAS-bleed score doesn't mean you cannot anticoagulate. That means you have to do more monitoring and you have to tell the patient that you have a higher chance of bleeding. Do you want to take this anticoagulation? Okay. So for just people who don't know CHAD-VASc, almost everybody knows it. This is C for congestive heart failure, hypertension, age more than 75, diabetes, stroke, vascular disease, age between 65 to 74. The score is 1. And sex category, females are given an additional 1 score. So here ladies are ahead of men. Okay. And this is the bleeding score chance. So there are a lot of scores that suggest if you will bleed or not. The most widely used is has bled, where H is for uncontrolled hypertension, abnormal renal hepatic function, separately given 1 point to each, stroke, bleeding history, labile INR, elderly, and drugs or excessive alcohol drinking, where you will be unable to manage the oral anticoagulants. And a score of more than 2 is high. Okay. When you look at the choices between oral NOACs, the newer oral anticoagulants, all of them are almost same to my understanding. A lot of trial data suggests otherwise, but you have to keep in mind never give them blindly in renal failure patients and patients with valvular issues. Never give it blindly in these two subset of patients. Okay. Now coming to ECG. Now this becomes a class of ECG from now. What is this? Who tells right will get free coffee outside. What is the rhythm? Quickly, quickly. This is atrial fibrillation. With what block? Complete heart block. I have not heard of that condition. So as I said, my most of thing will revolve around AFib. So this has to be AFib, right? So by the probability of the question, so this is a slow AF, and you'll see that very often. This is slow AF. Why? This is not a junctional rhythm. This is an AFib. Why? Because the RR is variable. You don't have a P, and this happens when the AV node is dysfunctional, either because of ischemia or overdosage of disoxin and CCBs and other drugs, which are blocking it too much. And this is what you see, and a lot of people see this in ICU and don't know this is a slow AF. Okay, so AF can be a bradycardia. That's a new learning point. Okay, now what is this? ये सबको पता है. Okay, जिसको पता है बता सकता है ये कौन सा एटीएल फ्लटर है? Is it a 2:4? There is no block called 2:4. This is a variable block. AFib, atrial flutter is mostly it doesn't have frequency, it's a variable block. It's a variable block. Okay. So atrial flutter, to keep it simple, is AFib. Okay. People say it is easier to convert atrial flutter into fib and treat it, right? Because then the AV nodal block becomes stronger and persistent. Because atrial flutter, the problem is the AV node is not refractory enough, and a lot of atrial conduction is to the ventricles, and the rate of the ventricle is very high. So the treatment of atrial flutter is almost as AFib. The only two differences is one, the antiarrhythmic requirement, the duration is less, and the need for anticoagulation is less. Rest everything is same. Okay, and a lot of patients have got atrial flutter fibrillation. They switch between flutter and fibrillation all the time. Okay, what is this? Tachycardia. Okay, narrow complex. Do you have a P wave? Do you have a P wave? No. So what is it? Is it regular? RR regular? This is regular. This is SVT. Paroxysmal supraventricular tachycardia. Treatment here is depending on stable, unstable. If he's unstable, and if you don't want to shock, what else can you give in unstable patient? Adenosine. In which patient you should not give adenosine? Asthma. Don't give it to an asthmatic, you will kill him. Okay. Okay. And if he's stable, then what do you do? Vagal maneuvers. Okay. Don't do it bilaterally, you kill the patient. And then you use adenosine. And to maintain the rhythm, if you have converted and you want to maintain, then you use CCBs. Okay. You may use diltiazem, you use verapamil, and you can use beta blockers to maintain the rhythm, not convert it, maintain the rhythm. So what is this? Very commonly seen in ICU. You have a P wave. 1, 2, 3, all are P waves, right? So, polymorphic atrial tachycardia. Bad. So multifocal atrial tachycardia. This is defined by more than 3 morphologies of P wave. This is one morphology. This is the second. This may be the third, and you have maybe 2 more morphologies, right? So more than 3 morphologies. In which subset of patient do you see, Matt? COPDs, especially the ones who are getting a lot of theophylline for years from their pulmonologist, CST for 3 months, theophylline. So they tend to develop. How do you treat it? You treat the cause. You treat the cause. And if you're very eager to treat it with CCBs, verapamil. Okay? Okay. For ease, I've given a diagnosis. Normal sinus, you have a first degree heart block. That basically means a slight prolongation of P wave, more than 200 milliseconds, mostly degenerative, seen in a lot of elderly disease heart patients. What do? Nothing. Watch. Second degree heart block type 1, Wenckebach's phenomena, progressive prolongation of PR, and you skip a beat. What do? Keep a watch. Now the second degree heart block type 2. Now this is a 2:1, 3:1, 4:1 block. What is this block? 1, 2, 3 beat. 1, 2, 3 beat. How what is a block? 3:1. 3 to 1 conduction, right? Do you do something about it or keep a watch? These are mostly symptomatic. You have to do something. We'll see what we need to do. And the third degree heart block, at times people may miss a complete heart block. They say, this is sinus rhythm. But this is a P, this is a QRS, this is a... You see, the P is independent of the QRS, right? The P is regularly placed, independent of the QRS. So there's a complete atrial ventricular dissociation. This is a complete heart block. And most of the time it is symptomatic. How do you treat? If they are symptomatic, only then you treat. You treat them with atropine, you pace them, transthoracic, transvenous. Okay. Now what is this? इंटरेस्टिंग नहीं? ओह मैंने ऊपर आंसर ही दे दिया। ये तो गड़बड़ हुआ। Okay, so this is a monomorphic VT. So how do you define a VT? VT is ventricular tachycardia. If you have more than 3 ventricular premature beats consecutively, it is a VT. Very simple. इतना नहीं चाहिए, 3 बीट कट्ठे आगे, that is a VT. Sustained and non-sustained VT. If you are sustained for more than 30 seconds, it is a sustained VT. If it is less than 30 seconds, non-sustained VT. Which is more common? Non-sustained. You see very often non-sustained VT. Patient who are unstable in shock. You see these non-sustained VTs coming in. What do you do for VT? You see, is it a pulseless shock VT or a hemodynamically stable VT? If you are hemodynamically stable VT, drug management. If you are hemodynamically unstable patient, cardio. Okay. So in case of VT, there are two types, monomorphic and polymorphic. Monomorphic and polymorphic. In monomorphic, what you see is this, right? Can you differentiate this from atrial fibrillation with the LVB or antidromic conduction of an SVT? Both will have broad QRS look at VT. And for that you need certain criteria. Okay? Which is that criteria? Brugada criteria. Brugada criteria is for diagnosing this is a VT. If you feel a fusion beat, a capture beat, these things point towards that. I won't tell you the detail of this. This point, this is a VT. Because a lot of time you are unable to differentiate a VT from a AF with a block. Okay. Next. What is this? ऊपर ही लिखा है, ये animation did not work here. Okay. The difference here is you have a varying amplitude QRS and a varying axis at the same time. Amplitude and axis are variable. In which condition do you see torsades? Prolonged QT, MCQ question, right? And what else? Ischemic myocardium, very commonly ischemic. The difference here is you treated with magnesium, right? Torsade is notorious to deteriorate into VFib, ventricular fibrillation. So take it seriously, convert it early, okay? And last rhythm, easy, ऊपर लिखा हुआ है, ventricular fibrillation. What do you need to differentiate ventricular fibrillation from? A flat line, asystole, right? You have that flat line protocol, check the leads, increase the amplitude. Because a lot of time you miss a fine VFib as a asystole because you did not really increase the amplitude. What is the treatment of ventricular fibrillation? Shock, right? Thank you very much for your listening.